শুভ সন্ধ্যা বন্ধুরা, আপনারা সবাই কেমন আছেন? আসলে প্রফেশনের ডেভেলপমেন্টের জন্যই আসলে আমাদের এই আয়োজন, বিশেষ করে ফিজিও নিউজ 24 এর। এবং আমরা প্রত্যেক রবিবারই চেষ্টা করছি পৃথিবীর বিভিন্ন দেশ থেকে গুণীজনকে নিয়ে তাদের কাছ থেকে কিছু মূল্যবান কথা শোনার জন্য। তো তারও ব্যতিক্রম নয় আজকে। এবং আজকেও আমরা আমাদের সাথে একজন আহ, গুণী ডক্টর প্রভাত রঞ্জন স্যারকে আমরা নিয়ে এসেছি। উনি ইন্ডিয়াতে আছেন এবং ইন্ডিয়াতে এইমস এ কর্মরত আছেন এবং উনি 20 বছর ধরে এই পেশার সাথে জড়িত। বিশেষ করে নিউরোলজির বিভিন্ন সমস্যায় উনি যথেষ্ট বিশেষজ্ঞ হিসেবে দায়িত্ব পালন করেন। এছাড়া এই নিউরোলজি জগতে ফিজিওথেরাপি চিকিৎসকদের উনি শিক্ষা দিয়ে থাকেন। বিশেষ করে আমরা যেটা বলে থাকি যে বোবাত অ্যাপ্রোচের উনি বেশি দক্ষ। তো কথা না বাড়িয়ে স্যারকে আসলে আমরা ইংরেজিতে আমন্ত্রণ জানাবো, কারণ আমাদের সাথে আসলে দেশের গণ্ডি পেরিয়েও পৃথিবীর বিভিন্ন দেশ থেকে আমাদের এই অনুষ্ঠানগুলোতে পার্টিসিপেট করেন আমাদের যারা ফিজিওথেরাপি চিকিৎসকরা আছেন। তো তাদের জন্যই আসলে আমি চাচ্ছি যে পরবর্তীতে ইংরেজিতে আপনাদের উপস্থাপনা করার জন্য। So, welcome everybody, and welcome our today honorable guest, Dr. Prabhat Ranjan sir. And I would like to invite all of my participants from this country and also abroad, especially from India, Pakistan, and Sri Lanka, Nepal. A lot of people are from participate in this platform in different countries. People, so I would like to request our honorable speaker today, because he is one of the famous fellows in India, especially on neurological condition, and he used to give lecture on Bobat approach in India. And I have requested sir, and I have a good relation with sir from last 5 to 6 years by Facebook, and he's a very nice person and very familiar person, with always busy with families and others fond of physiotherapy professional development work. And Bob, for neurology, I think it's a vast chapter, and it's not a single issue we can deal with. But for neurological condition, always we think that there is a 50-50 chance for physios. So I think today we're going to learn some new topics on Parkinson's disease, because nowadays it's a very common disease in our country or all over the world. So during that time, we are physios, and all of our general participants, they can try to understand what we're going to do in this type of condition. And sir, he has a great experience on neurology. This is more than 20 years in this field. I think today he will explain the nice topics and nice things about. So thank you, sir, and over to you, sir. Please, sir, it's time for you, sir.
Thank you very much, Dr. Shantanu, for inviting me on this Physio News 24 platform, and I am very much honored to be on this platform. And I will be talking, as you said, that Parkinson's disease management, right from the pathophysiology definition, and then the special exercises, what can be given. I will demonstrate the exercises also. And you said rightly that sometimes neuro becomes very challenging. So we have to, as a neurophysiotherapist, there are certain challenges in treating the patients, but anyhow, we have to give the results, and that result, what we get in the functional outcome, really boosts the morale of the patient, and this gives us also a satisfaction. At least we are helping them to lead a good quality of life. So in this direction, today I will be talking on the topic that is the Parkinson's disease, recent advancement, and impact of artificial intelligence. I will be sharing the screen. If any technical problem is there, just let me know, because sometimes there are technical problems going virtually. So you are able to see my PPT?
Sir, is still not coming, so we can wait for that, sir.
PPT is not coming.
No, it's still not coming, sir. Just check it,
Yes.
sir.
Yes.
So Dr. Shamim is behind with us for the technical issue. So I would request
Yeah.
Shamim to, yes, help for the other stuffs now.
You are able to see my screen, I think.
Still not, sir. Dr. Shamim, you can help me. Yes, sir. Now it's open.
Coming?
Again, try, sir. Not now, sir. Still not. Just open your PPT.
I'm opening. No, I'm not able to see my screen also.
Okay, sir.
Now it's there.
Okay, sir.
Now the screen is visible?
Yes, sir. That's okay.
Yes. So
you
as
can continue. Yes, sir. You can continue, and I'll be off now, sir. Okay.
Yeah.
Shamim. Yes, I have to leave now.
Just I will stop the camera, then you will stay fine.
So your camera is off now.
Camera I have off because sometimes what happens that it takes more of the data.
No, sir. You can open it, sir. We will come. That is, Dr. Shami will handle everything, sir.
Okay, he will handle it. Okay, then I'll on my camera.
I'm just taking leave, sir.
Yes, fine. So, a very good evening to everyone. So, I will be starting with my presentation. The Parkinson's disease, as you all know, that is a brain disorder, and it leads to the shaking, stiffness, difficulty with walking, balance, and coordination. It is a progressive disease, as we all know that it is a progressive disease, and slowly and gradually it progresses over the time. And as the disease progresses, the subject or the Parkinson patient feel difficulty in walking and talking, and apart from this they may have the mental problem, behavioral changes, sleep depression, sleep problem, depression, memory difficulty, as well as fatigueness is there in their activity. When we see gender wise, then there are men and women. If we will see, then 50% more of the men is affected than women, and it has been seen in many of the diseases that pathophysiology, when we'll check that men are more inclined towards any of the pathology we are seeing of, even stroke we see, even in this Parkinson's, and even in this pandemic COVID-19, we have it has been observed that men are more affected than women, 20% more than women. And in Parkinson's also 50% more of the men is affected than women. It is known as a disease of elderly, and nearly 90 to 95% of the cases is of around you can say 55 to 60 years, and above 60 years 5 to 10 years is of 45 to 50 years. Nowadays we can see the juvenile Parkinson's also, and that too also accounts up to 1 to 2%. And sometimes Parkinson's has been linked to the specific gene mutation, but basically it is the pathophysiology which will go, it is related to the dopaminergic neurons which is secreted in the parts of the brain which is known as basal ganglia, and that part is substantia nigra, parts where this dopamine is secreted, and this dopamine in combination with the neuromuscular junction, one acetylcholine is there, it controls the movement, and this movement is controlled in combination with the dopamine and acetylcholine, and the loss of control of the movement is there, and due to that tremor is there in the Parkinson's disease. That's why the control movement is not is in control. That's why this disease has also been put in the category of movement disorder, because here the movement is impaired in the subject's body. There are four classical signs in the Parkinson's disease, and that is the bradykinesia, muscular rigidity, resting tremor, postural instability. These things, these four cardinal signs are there. Bradykinesia is the slowness of movement. It is known as the one of the positive feature in the Parkinson's disease, because what happens that tone is there. When tone is there, then movement can occur in the body. When tone is not there, then the movement will not occur, but at least tone is there. That's why it's known as a positive feature, so that some amount some movement can be done, and it is helpful in performing the activity of daily livings. So bradykinesia, there is slowness of the movement, the symptoms are there, but the subject can do the movement, and as per the movement or the functional activity, the subjects it has been divided into these stages. Then second is the muscular rigidity. Muscular rigidity is the increase in the tone of the muscles of the flexor and the extensor group, that is the agonist and the antagonist of the muscle group. And muscle rigidity has been known as the one of the negative feature in the Parkinson's disease, because it leads to the other difficulties such as bradykinesia and tremors and all that. So muscular rigidity is one of the negative feature in the Parkinson. It is of two type. One is cogwheel type, and the other one is the lead pipe type. In cogwheel type, when we will do the movement, we will feel the resistance throughout the movement, that is the extension and extension and the flexion. Or suppose we are doing the extension and flexion of the elbow, we will feel the resistance throughout the movement. Then is the lead pipe type. Lead pipe type means lead pipe you must have seen. When you are bending lead pipe, what happens? Some degree you will feel the resistance, some degree you will not feel the resistance. Thus that same thing happens while doing the movement. When you are doing the flexion of the elbow, first 10 degrees you will not feel, but another 10 degrees you feel, again another 10 degrees you will not feel the resistance, but again coming forward you will feel the resistance. So on and off, and the resistance is there. So this is type of the muscular rigidity. Then is the resting tremor. Tremor also can be divided into two parts. That is one of the resting tremor, and another is the functional tremor. In resting tremor, when the hand is in resting, that will be shaking, the tremors will be there. As soon as you will go for some function, suppose you are going to take a glass and drink water, then what happens that as soon as it becomes in function, the tremor will be absent. But sometimes what happens that during the function also the tremor is there existing, then that is known as the functional tremor, resting tremor, and then functional tremor. So just if I'll show you some video also, if I can show you, that may give you some good view of that picture. Just a minute. Videos of some patient may give you some better idea. So here I will. Here you can see in this video that in resting she is having the tremor. As she will go to take the cup, the tremor is absent, and then she is able to do the activity. So here you can see that tremor is absent. So this is the one of the feature you can, this will give you an idea. One more, this is the gait. I can show you some more. So as she is walking, she needs help. One more video is good video is that. So here you see that tremor was there, but here you see as she is doing some function, the tremor is not there. So she is having the resting tremor. So you can elicit that she is having resting tremor. Fine. Thank you. So now then there is postural instability. Postural instability is due to the there is a tendency to stoop forward. Their gait becomes very short, shuffling, and the movement of the hand movement becomes very limited, restricted, and this leads to the postural instability, and there are a history of fall in the subject of the Parkinson, and depends upon the stages of the Parkinson's. So symptoms of Parkinson's and rate of progression will differ individual to individual. Early symptom of Parkinson's disease is stubble, and it gradually affects. It may start from one side and then the other side of the body. It is not the same intensity will be there on the, say, on the both the sides. There may be some increased intensity in either of the side, or there may be same intensity, but it is not always there. So their handwriting, in terms of handwriting, it will be cramped. The expression, the facial expression will be very much there will be very less facial expression. It is said that mask like face is there. Puffiness in the face will be seen, redness in the face will be seen as we wear a mask, and though it is expression less, there is no expression at all. So the Parkinson's has been divided into the stages. A stage has been divided into the functional outcome. As per the functional outcome, how the subject is able to perform his activity, it is depending upon that. And stage 1, what happens that the symptoms are there in the subject, the tremors will be there, the rigidity will be there, the slowness of the movement will be there. But even though in that condition the subject is able to perform his task without any difficulty independently, then we can say that the subject is having stage 1 of the Parkinson's disease. Then in stage 2, what happens that those symptoms are there, but it gets worsen, and when it worsens, it leads to increase in the length of performing any task and decrease in the intensity. Suppose I am doing flexion extension 10 times in a minute, but with Parkinson's I may not be able to do more than 2 or 3 repetitions. So there is a decrease, and that 2 or 3 repetition which I am doing in 2-3 seconds, it will take around it may take around a minute to complete 1 or 2 repetition. So the intensity is also decreased, and length of performing the task has also increased. But in this condition also the subject is able to do the perform his task, though the length of performing the task is increased, then that stage can be considered as a stage 2 of the Parkinson's disease. Then comes the stage 3. Stage 3 is a mid stage. We can say that mid stage, because what happens that in stage 3, some of the activity the subject can do independently, and some of the activity he will need some assistance, such as dressing, such as doing some walking also. Sometimes suppose he is able to get up from the bed or get out of the chair on his own, but when he or she starts working, he needs some assistance. So at that time, what will be there, that some of the assistance will be needed at some time, and sometime the assistance will not be needed. So that stage can be considered at stage 3. And in stage 4, what happens, the functions becomes very limited, and the subject needs to needs some assistance to walk, and the subject cannot live independently. For this also I can show you video of the same patient, and you will get some idea that yes, those. So this so here you see that she is trying to get up, and while get up, what happened that she is taking minimal assistance. She is trying to do the caregiver is assisting her, and now she is able to sit from the lying, and that when will be then when she will be standing also, she will be needing some little amount of assistance. I will show that video also, that how she needs assistance in standing. That video I know, I think while getting up from the chair also she will need the assistance, and while walking also here she is needing some assistance. So you can say that she is of a stage 4 of the Parkinson's disease. See, well, while she is also sitting, also she is sitting on her own, but that it's not so smooth. So we can say that she is having some amount of the movement she is doing independently, but some amount of the movement she is not doing independently. So we can categorize her in a stage 3 of the Parkinson's disease. Then is the stage 5. Stage 5 is one of the advanced stage of the Parkinson's disease, and in this what happens, there is severe stiffness, there is freezing. Freezing is there in a stage 3 or 4 also, but here what happens that it's very tough to do the activity. The subject is rigid, his muscles are rigid, he is nearly bedridden, and he will not be able to perform any of the tasks with the minimal assistance also, or with the assistance also. Here he will need round the clock nursing, and all the activity will be done by the caregiver fully, then not partially but fully. In stage 4 the partial assistance also will work for the subject, but in stage 5 it is nearly bedridden. So this stage is one of the advanced stage of the Parkinson's disease. So apart from these were the stages defined on the motor movements. Apart from the motor movements, there are non-motor disorder also in the Parkinson's disease, and non-motor disease are the early sign of the Parkinson's disease. And in this, what happens that it may be noticed by the family members or the caregiver or the close friends. They can only notice that this non-motor movement, suppose his cognition level will change, his sleep disorder or sleep pattern will change. So these things are the symptoms of the non-motor disorder, that is the cognitive changes, constipation, early feeling fullness of the small meal, excessive sweating, fatigueness will be there, loss of smell and taste, because what happens, Lewy body, one type of protein is there that is accumulated in the area of the olfactory part, or even in the basal ganglia, and this is there, Lewy body is accumulated. This is the bad protein, and then it affects the smell or taste also. Mood disorder is there, such as depression, anxiety, irritability. Sleep disorder is there, sexual disorder is there, urine urgency is there, incontinence will be there, vision problem is there, and after weight loss is also one of the feature in the Parkinson's disease as a non-motor disorder. Though motor disorder are visible, this disorder will be only noticed by the close friend, family, friends, and these are the early signs, and this helps the subject in getting early diagnosis. And when early diagnosis is there, then delay in the progression will be more. We can delay the progression more. Apart from this, one scale is there to rate the functional outcome of the Parkinson's disease patient, and this scale is very important. This is a very vast scale, this is a big scale, and it do combines all the functional activity nearly in the Parkinson's disease, right from the mental behavior to the motor movements, to the activity of daily living, gross movement, fine movement, gait training, gait, how the gait is there, how the freezing, how much is the freezing, and how often the freezings are there. So these things can all be accumulated in one scale that is known as UPDRS. U and stands for unified, P stands for Parkinson, D stands for disease, R stands for rating, and S stands for scale. So unified Parkinson's disease rating scale is one of the standard tool to assess the subject for the functional outcome, and accordingly we can treat the subject, and it also helps in getting a good research also. And the total count is maximum overall activity. If we will count, then it goes up to 199. If one is scoring, then in this scale, then this is the worst disability the subject is having in the Parkinson's disease. And if one is scoring 0, then we can say that he is having the one of the good functional outcome, even he is suffering from the Parkinson's disease. And the scaling, there are 5 scales starting from 0 to 4. 0 is normal, 1 is mild slowing or reduction in the amplitude, 2 is the moderately impaired, definite and early fatigueness, may have occasional arrest in the movement, and 3 is the severely impaired, frequent hesitation in movement, and arrest is there. All there will be certain ongoing movements, and when he is walking, then freezing will be there. So there movement arrest is there, that is can be that can be scaled as 3 and scored as 3 in the scale, and 4 where he barely performs the task. So overall 5 rating scale is there, and this scale is maximum 199, and 0 is the minimal deficit in the Parkinson's disease in functional outcome. So when the Parkinson's disease, when we go to the treatment part, the treatment is physiotherapy treatment as well as the medical treatment is there. When physiotherapy treatment we talk of, then it mainly focuses on the neuroprotecting and endurance, motor learning principle approaches, muscle balance retraining, then endurance, strength increase. So this can be helpful in making the subject delay the progression and to lead the good quality of life. Group setting, group discussion, group exercises are also very much helpful in the Parkinson's disease. And apart from this, we can ask the subject to do the dual task performance, because dual task performance becomes quite difficult in the subject of the Parkinson's disease. Suppose he is walking, then if you will ask him to do the subtraction of 5 minus 3, then he will suddenly will have a imbalance and he may fall also. So at the time when you will ask some cognition with while doing the motor function, then there may be problem, and if you will ask him to catch a ball while walking, then he may have problem and he may have fall. So dual task training also should be given, and the exercises should start from simpler to complex form. We should start with simple exercises and then take it to the complex form as per the assessment, as the assessment and reassessment continuous should be done. And when we find that the subject is having a good control, then we can move forward with the dual task training. When we go to the medical part, dopamine it is given by the physicians, and this dopamine and all that supplement substitute drugs are being given to the patient who has suffered from the Parkinson's disease, so that the brain chemical which has affected the body can be compensated through the medicine. And this medicine as doses is being as per these stages of the Parkinson's disease, the doses is being considered by the doctor after thorough investigations. Apart from this, one surgical process is also there, and in the Parkinson's disease, that is known as deep brain stimulation. Deep brain stimulation is a surgical process where surgically electrode is implanted into the brain, and when small device is connected and implanted in the chest, and this device, an electrode, painlessly stimulates the brain in a way that helps to stop many of the movement related in the Parkinson's symptoms. Sometimes there is a kinesia in the Parkinson's disease, means awkward movement, involuntary movement of the body, such as is dancing. So akinesia is there, and when it is in severest form, there is very much difficulty in performing the ADL, and at that time, if DBS is done, then sometimes many of the times it has seen that it has have shown a good result, and it has improved the movement related symptoms, and controlled movement is little bit there. So involuntary movement little subsides in such a manner that subject is able to perform his task. So akinesia, Parkinson's, or in stage 5 or 4, it is very much helpful. DBS can be done, and with this physiotherapy should be advised, because we should be combining with this device the exercises, because we need to get a good functional outcome. And apart from this, one thing is in Parkinson's disease, that is the on and off phase. There is on and off phase. On phase is that when some drug is being administered, the Parkinson's disease drug is being administered to the Parkinson's patient, then what happens, that the symptoms subsides. That is known as on phase. The symptoms such as in rigidity, bradykinesia, and the tremors, that subsides or become absent. It is absent. When it is absent, then it is on phase. And in this on phase, if we are trying to give the exercises, then it will have a better functional outcome in the subject, and it will also maintain all the things of flexibility of the muscle, elasticity of the muscle, mobility of the joint. It will also help in increasing the strength and the duration of the endurance of the subject. And as the drugs start wearing off, means the effect of the drug is declining and the symptoms is coming back, then it is known as off phase. So it may be depending upon person to person. Sometimes 4 hours may be the on phase, or 6 hours may be the on phase, 8 hours may be the on phase. It will depend basically on person to person, that how much the drug has been affecting him, to how long it has been affecting him. And as per the dosage is also set by the physician. So we should correlate or coordinate in such a manner that we should give the exercises in the on phase, and the patient is comfortable, and should give the exercises on his own pace. So the exercises is given to maintain the musculoskeletal flexibility. For the need of the thoracic expansion is there, because what happens, stooping of the posture is there, and due to stooping of the posture, the muscles of the respiratory muscles doesn't work up to the maximum. So deconditioning of the chest thoracic expansion is to be given. We should prevent the psychological decline, because psychologically also patient is depressed, so we should prevent that. And with the exercises, what happens, that regular exercises, it secretes some enzymes like serotonin, endorphin, to keep the psychological level high, encourage the lead to active life. So we should encourage the subjects to lead the active life, as well as our duty is to prevent the contracture, deformity, and stiffness of the joint. So physiotherapy mainly is to improve the mobility, flexibility, strength, gait speed, aerobic capacity, and definitely it is to lead good quality of life. So I will explain some exercises in this Parkinson's disease. Some special exercises. One will be the balance, for the balance, and other will be for the increase of the strength and duration. So we will start with the first. I'll show you the videos of the exercise, so that may give you some idea. So this is the exercise for the balance.
I am Prabhat, Ranjan,
be demonstrating you balance exercises for the Parkinson's disease. And as Parkinson's disease patient face problem in balance, and these exercises are very much helpful in balance retraining, which may help the subject of Parkinson's disease to balance themselves and have a better coordination and prevent from fall. This is the first exercise in standing position. For this, we can keep a chair nearby also when the balance is not proper. So we keep a chair, or we can do it without the chair also. So the first thing is that standing upright with the feet apart and the face facing forward. Stand in this position for 30 seconds, and then again we can make our feet close and stand upright for 30 seconds. If we face difficulty in doing this exercise, we can take the help of the chair. We can stand with the feet apart for the 30 seconds, and then with the help of the chair, support of the chair, we can bring our feet together and then again stand for 30 seconds and try to wean off the support of chair slowly and gradually. This exercise is making the feet forward for the balance, and this should be kept in such a manner that the toe of one leg should be touching the heel of other leg. Just we can see this like this, and we can stand for 30 seconds. Then again back, then again the left leg should be in front of the right leg, touching the toe of the right leg with the heel of left leg. If we face problem in doing it independently, then we can take the support, or any parallel bar should be there, and with that parallel bar also we can take the support. With the chair, put the hand on the chair, and then we can make forward our limb to the other limb. Then again holding for 30 seconds, then the next leg in front. First we should start with the support exercise, and then slowly and gradually progress to the independent exercises. This can be performed in dynamic way also. For dynamic way, it is known as tandem walking. So we can put up bars, and then we can put, suppose right leg we are taking into the front, it will be touching the toe of the left leg, heel will be touching the toe of the left leg, and then again we will move forward. This is known as tandem walking. Without support also we can do this. Take the right leg in front of the left leg toe, the heel should be touching of the right leg with the toe, and then again in front. This we can repeat for both the right and left leg. Next is the single leg stand. I am showing first the modified way how we can do the single leg stand. We can put a stepper in front of our body, in front of the body, and then we can put one leg on the stepper for 30 seconds, and then we can take down the right leg, then we can put the other leg on the stepper for 30 seconds. This is the modified way, and this we can repeat for 10 repetitions. The other way of doing this exercise is single leg standing, is without any stepper. We can put the leg on in the air as much as it is possible. Minimum 30 seconds it should be kept with the right leg and as well as the left leg. Next is lateral balance. For this exercise, we will be standing upright, both the legs apart, and then we can take the right leg as far as we can take and then support. Then we can come back to the starting position. Then again, we can go as far as we can take the other leg and keep it on the ground, and then we can come to the starting position. This we can hold it for 3 seconds and then come back to starting position, doing 10 repetitions for each leg. So next is the backward walking. backward walking, modified as well as dynamic. In modified backward walking, we can take our right foot backward for one step, first putting the heel down and then coming forward to the starting position. Then repeat it with the other leg. This can be repeated for the 10 repetitions. This is the modified backward walking. And then we can do it a dynamic backward walking. We can walk with the one leg, then we can repeat it with the other leg. This. Again, we can see this, how the backward walking can be done. Backward walking with the other leg, and then this. This may help you in getting the balance of the subject. This is the forward step. We can take the one step ahead of one leg, that is the right leg I am keeping, then come back to the starting position, then same we can repeat with the other leg, that is the left leg, and then we can come to the starting position back, and this can be repeated 10 times at a time. Next one is the quick step. Quick steps helps us to balance when there is sudden trip in our gait. Suppose we are doing it for forward bending, when we are walking forward, then suddenly we fumble up and then we have a fall. So this can be also practiced, because in patients with Parkinson, they are not able to take quick step. So how to take the quick step and develop this coordination? First, for the forward, we can see that we will shift our body weight forward, and then suddenly we will take one leg ahead. This we can repeat with the other leg also. Take the body weight forward. As we feel to fall, we will take it other leg also forward. So this quick step will help us in balancing while we are moving forward. Then the lateral, to have the lateral quick step. So we will laterally shift the body weight, and as we will feel we are falling, then ask the subject to take the one limb apart from the other limb. So this hold for 3 seconds and then come back to starting position. Then again for the other side, as we are falling, we'll keep hold for 3 seconds, then again on the starting position. This we can repeat for 5 times. Next is the dynamic balance exercise. In this dynamic balance exercise, we can make the patient to walk in the figure of 8 structure. We can put 2 blocks in front, make the subject walk in a figure of 8. Suppose he is walking, he can take these steps and make a figure of 8 by coming into the. This can be repeated 10 times. Apart from these dynamic exercises, this figure of 8 exercise, we can do more of the dynamic exercise to improve the coordination and the cognition also. This was the motor training for the coordination, but for the cognitive also, we can ask the subject while walking, he can subtract 5 minus 3, or he can add 5 plus 3 during walking, because this will help him in cognition. More for motor, he can take any object, he can even take the mobile phone, and while walking he can do some activity in the mobile phone. So this will also lead to the coordination improvement in the subject.
These are all the dual tasks. So dual tasks can be also done in this while walking or while giving some exercises. That is also important. So now I'll show some other video that is related to the strength and duration exercises. So this will be also of much help to you all.
Hello, I am Prabhat, Ranjan, and I'm a Neurophysiotherapist. I am here to explain about some of the strengthening exercises for the Parkinson's patient. Because it has been observed that
as the time goes or you grow older, the muscle strength lowers down. And especially in the cases where there is some disease, then it has been observed that it is much weaker than the people of similar age with no any other neurological problem. In Parkinson's also, this happens, and the subject who is suffering from Parkinson's are having a weaker muscle in comparison to the other individual who are not having any neurological disorder. So we can go for this training program. For that, some points has to be taken care. One is that there should be a suitable environment. For that, we have to make sure that proper support is there so that one should not fall. The symptoms should be well within the control. Suppose if the subject is having on phase, then he will be able to do the exercises properly, but as soon as he goes into the off phase, then he will have some problem. The exercises should be done 3 times a week. Take a rest in between a day. One day you do the exercises, the other day you take a rest, so that the muscle doesn't pick up so much of heat. One thing or more is important, that the exercises should be done at any individual of Parkinson, that the pace should not be much higher or much lower. Whatever pace he is having or he is generating himself, at that pace only the exercises should be done. So now I will demonstrate what are the simple exercises for the strengthening of the muscle. So take a chair. The chair should be firm on the ground, and make sure that it doesn't slip while getting up. Initially try to have the chair with the armrest so that the subject who is suffering from Parkinson's can take the support of my lateral armrest in order to get up. This exercise should be performed 10 times at a time, and you can make a set of 10 repetitions. 10 set, then take a rest, then 10 set, then take a rest, and then 10 set. So we can do it in this way. Take the support of the armrest. With the support of the armrest, the subject will get up, and then again he can flex his back and then sit down. Like this, he has to perform 10 repetitions, and slowly and gradually as the time overcomes and he is feeling confident, the subject, then he can stand up without the armrest, help of the armrest, and then sit without taking the help of the armrest. In this, we can adjust the height of the chair, where we can start from the comfort level of the subject. If we have to make the height of the chair higher for his comfort level in order to perform the sit-to-stand exercise, then keep the level of the chair higher. Slowly and gradually we can lower the level of the chair in order to build the muscles of the lower leg. This may help in developing the balance of the subject. So for that, take the support of the chair. The chair should be firm on the ground, it should not slip. Stand upright, look in front, take the support of the chair, and then go on your heel, and then slowly come down. Do it for the 10 repetitions, then down, 10 repetitions, then down, then take a rest, again 10 repetitions, then take a rest, and again 10 repetitions. This will help in developing the muscle of the calf, as well as also help in getting the balanced movement while walking. It's standing, and that is lateral step up. So keep one of your leg or stepper, and then with the help of your muscle power, the body weight, just get up, hold, and then come down. Hold, come down. This also 10 repetitions. Wait for some time, 10 repetitions, take rest, and then 10 repetitions. If you are not able to do this exercise independently, as there are some stages in the Parkinson, stage 1, stage 2, stage 3, to stage 2 or 3, sometimes may need some support. So keep a chair by your side, or you can take the support of the wall, stand against the wall laterally, and then put the one leg on the stepper, and then with the help of the support, you can do this movement. This will help in gaining the strength of your quadriceps muscle, as well as your calf muscles, as well as your front foot muscles. So this will help you in gaining the balance also. Exercise is sliding down, or you can say the half squat. Take the support of the wall, put the leg little bit front, and then the help of a body which is upright and is touching the wall, just slide down, and it should be as such that it should not cross over your toe, greater toe. It should be near the toe or about at the parallel to the toe. It should not be in front of the toe. So get down, then up. If any problem in doing independently, you can take support of the wall, stand like this in the wall, and then go up, and then go down, then go up, then go down. This also 10 repetitions, take rest, then 10 repetitions, take rest, then 10 repetitions. At the middle of the TheraBand doesn't get squeezed. Make sure that it is not squeezed, and wrap in your hand. Put it in such a fashion that attention is developed in between. Attention is developed. So now I think that attention has been developed. Take the flatter part and then put it in the middle of your both leg, and the tension is developed. So keep your arms straight, sit upright, and then flex your elbow. In the meantime, try to squeeze your blades, scapular blade, and then open up the chest. This time, we can do it 10 repetitions to strengthen the upper muscles. Like this from the back, and the scapula will squeeze, both the scapular blade will come together, the chest will open up. Also done. For the quiet strengthening, put the TheraBand in the middle so that it should not slip. Put your hand straight, slip, and then slowly take a 90 degree straight, and then down, then other hand straight, then down, then other hand straight and down. It should be done 10 repetitions, but if you are any of the subject is not able to complete the repetition of the 10, then 5 sets also can be done. Then further we can proceed bilaterally also. Put the TheraBand underneath your foot, stable, and then bilaterally we can proceed. Then we can also do it for the elbow. Tighten the TheraBand, and then up and down. Flex your elbow, straighten up. Flex your elbow, straighten up. Flex your elbow, straighten up. Same this way. Flex your elbow, straighten up. Flex your elbow, straighten up. This can be done 10 repetitions. not able to perform, then make a set of 5-5 also, so that slowly and gradually the subject can progress on the 30 repetitions per 10 seconds. So now for the strengthening of the lower limb, suppose you want to strengthen the muscles of the lower limb of the right side, and how we can put the TheraBand, we should tie it over the leg which we want to strengthen in such a manner that it should not slip. Then the other end should be at your other leg. Put it in the middle in such a way that attention is developed here. So put it here. You can either you can hold with your hand, or you can just put it underneath the chair. Hold it firmly with this leg and then lift up and down. Lift up and down. Lift up and down. 10 repetitions this leg, and the 10 repetitions after tying the same manner with this leg, and in that set you can do it for 30 repetitions in a set of 10. Then this exercise can be done in standing position also. We can take a hard chair so that we have to see that it should not slip. Otherwise, on a bar, any bar is there, we can tie this. Just this is for demonstration. I'll show you that we can tie it underneath the chair, one end, and the other end should be tied at the leg which we want to strengthen it in such a fashion that the tension is developed here. Then we will tie it. So this surface should be hard. Develop the tension. Then go this way, then out, this way, front, back, hold it, then front, and we have to stand upright, back, and up, back. This can be done for both the legs, one by one, 10 repetitions, take rest, 10 repetitions, take rest, then 10 repetitions. So when you go through the bands, there are several types of band. This is the moderate one. We can start with the low resistance band also. The red one is the low resistance, and the yellow one is one of the very low resistance. This yellow one is having very low resistance. Then heavy resistance is the blue, and the black one I'm not having, but blue I'm having. So blue and black one, as per the requirement of the subject, we can introduce the band, TheraBands. And this TheraBand exercise is very good in strengthening, and especially in the subject who are in stage 2 or stage 3 of the Parkinson's disease. There it can be helpful. Stage 1, it is very much helpful. So we can try these TheraBand exercises also, but please take care that the patient is stable. The object which we are using is stable. There is no chance of falling, and environment should be very much cordial for the subject. Apart from strengthening, we can go for stretching also, and stretching of the trunk is very important because this becomes stiff, and as this posture is stooped, and this restricts the movement. So we can do this stretching. A very simple stretching exercise is there. We can lie on the mat. We should lie on the mat. Flex both the knees. We have to flex both the knees, and when we are rotating the lower limb towards the left side, our neck should go towards the right side. Then again, if it is going to the right side, the neck should go to the left side. This way we can stretch. Other way, we can put the hand underneath the head. Second step, we can do that. This will stretch the pectorals as well, and then we can stretch the lower limb, and then we can take the head to the opposite side. If we are taking the limb to the right side, then the head should go to the left side, and we should make sure that our scapula as well as the elbow is not lifting up and it is stick to the ground as much as it is possible. There are many other exercises. These were the simple exercises which can be performed with standing and the stretching. Then a lot of exercises regarding to balance is there, and for that specific those exercises we should consult our physiotherapist or the treating doctor so that he can refer to the proper neurophysiotherapist. So neurophysiotherapists are, so apart from these exercises, for the other coordination can be given the Frankel exercises and all that are the conventional exercises, so we can go with that also. So these exercises we have shown that it has not been practiced regularly, so just with knowledge I have given you the exercises for the balance as well as to increase the strength and endurance in the Parkinson's patient. So this may be helpful in treating the subject and also in increasing the to decrease the rate of progression. So it will delay the progression also, and it will help in leading the good quality of life. So now we come to the another second part, that is the artificial intelligence in Parkinson's disease. This is very much now in practice as we are in this pandemic. We are virtually connected. We are using such things. We are doing telemedicine, teleconsultation for the patients, and when this will be there, this can help us in gaining the lead the this can help us in gaining the leading the good quality of life in the Parkinson's patient. So artificial intelligence in combination with the virtual reality can give good results. And when we go through the definition of the computer science of the artificial research study, it says it is a device that perceives its environment and takes action that maximizes the chance of successfully achieving its goal. A more elaborate definition can be characterized as system ability to correct interpret the external data, to learn from such data, and to use those learning to achieve specific goal tasks through the flexible adaptation. So this is very important, that a device is there which interprets the external things from us, and as per it perceives the internal thing, gives us the specific task and the goal to achieve, and with the flexible adaptation for the better functional outcome. So this is the artificial intelligence, and this is maybe in much more in use in a decade, because there will be some changes in the healthcare sector, and I think this pandemic has taught us to be technically very sound, which has been very much helpful in the, at least in the healthcare sector. So how it has helped with virtual reality and the artificial intelligence? For that, standard scales are there, which through which the pre and post assessment was done. Pre-assessment on the balance, that through the Berg's balance test. For the length of duration of the time, that is the tuck test, that is the time up and go test. As I said, the UPDRS scale is the VAS scale. Through that also assessment can be done, and when assessment is done pre and post, the difference can be noted. Here, for example, I have taken a treadmill, harness treadmill, how the artificial intelligence and the virtual reality is helping in gaining the movement in the subject. If, initially, when the subject is not having proper balance, then he is harnessed, as you can see in the picture, with number 4 is the harnessing is done, and slowly and gradually, as he is improving his that gait pattern, then balance is coming, then slowly and gradually the harness is being weaned off. So one, you will see when you go through the number 1, it is a 6x10 treadmill. Then 2, if you will go 3x8 rear projection, these are the projection view
from where he will see that he is walking in a natural condition. Though he will be walking on a treadmill, but he will feel as if he is walking on a natural condition as we walk on the natural things. Then 3 is the camera. There is the camera. These are the cameras which will give the proper interpretation, and the processing of the data will be there through. And then is the safety harness, as we have seen. So I'll show you video regarding this. Then this will give a good view that how this lady was there is getting benefited. She is doing the dual task also at that time. She is starting from the simple harness gait pattern, walking on the treadmill, and then she hitting the bird which is coming through on the screen and performing the dual task later on, and then later on she is able to walk without the harness.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
We know in neurorehabilitation, you have to challenge patients for them to get better. And so this provides a very safe environment for that to occur.
The virtual reality treadmill has 2 belts, one for each foot, and a base that moves to mimic different surfaces. It can also react and adjust to a patient's movement, and a wraparound video screen completely immerses the patient into a real-life scenario.
When I go over like a little hill, you feel it in the machine.
Rather than just having the patient walk or an individual walk up and down a standard biomechanical track, now what we can do is we can change the environment in a very dynamic fashion.
Special programs are designed to work on specific skill sets while providing positive feedback. During weekly appointments at Cleveland Clinic, Sandy works with her therapist on gait and increasing stride length by touching her toe to a box. Other times, she's asked to target birds and butterflies while walking. This helps with balance, and it satisfies that competitive spirit.
I enjoy doing the birds and the butterflies and swatting them down and killing them. Not that I enjoy the killing part, but I do enjoy the challenges. Can I get them? I know once I slow down, it could come to the point where I couldn't move. So I'm willing to do whatever I can to keep myself going.
At Cleveland Clinic, I'm Erica Foreman.
So you see that how in the last she was able to walk without a harness, so she had developed the control of the movement while doing the practice. And this thing has been done, as we all know, that the old proverb is there that use it or lose it. So when we are using the things, the brain is accommodating to that, and the pathway is created, and this it is maintaining the flexibility of the muscle, mobility of the muscle, and due to that the progression is delayed as far as the muscle is properties are maintained, the joint stiffness is not there, and the brain is retrained through this lot of practice and activity. So this may help, this is helping the subject in delaying the progression of the Parkinson's disease. So another video is that how this artificial intelligence is working with the help of virtual reality. There are sensors, wireless sensors, sometimes it is cumbersome, then laser sensors are there, which is wireless sensor, then wire sensors are there, then there is a movement interpretation for that, the magnetometer, accelerometer, gyrometer, these things are there, which helps in interpreting the external data, and then internally it is being affecting that.
The more I exercise, the better I feel.
Like most Parkinson's disease patients, exercise eases Mary Spletter's tremors, halted gait, and lack of balance. She recently took part in a UCSF study to see if special video games could replace her regular exercises. The therapeutic games are the result of a marriage between game developers and scientific researchers.
Well, UCSF had developed a series of exercise programs for patients with Parkinson's. And they asked us if we could actually make a video of it. And we said, you know, there's this new thing called the Wii. Why don't we make interactive games?
UCSF researchers thought video games might be a welcome change of pace from physical therapy, which can be tedious.
People very much like doing the games. They found them engaging, fun, and therapeutic.
But developing games that would know if patients were using the right muscles in the right way was tricky. Health games need to detect a player's movements much more precisely than their consumer counterparts.
So there's 3 different devices that you need to be able to sense where you are in a particular space. One is an accelerometer. Am I moving a particular direction? Another one is a gyroscope, which is which direction am I pointing? And then third, you need something like to say, okay, I need a rock solid north, and that's a magnetometer.
These 3 technologies enable smart devices to do this. To make the technology more accurate, the developers created suits with 9 built-in sensors.
They were a big pain.
The battery-operated suits were awkward and cumbersome, so the developers turned to camera technology.
It's bathing you in infrared light, and then taking that information and using some very clever software to say, you just raised your hand.
The camera technology does not need to be worn, but it's not as accurate as the sensors.
Each one has their pluses and minuses, and we're looking at actually trying to perform a fusion between those 2 technologies.
The UCSF study showed that despite their physical limitations, Parkinson's patients could successfully play the games at home. And they did them more often because they enjoyed them and they helped.
It was a fun way and an easy way to exercise right in my own front room at any time. I felt better. I felt more normal, more fluid and looser.
In fact, the study found that after playing the games for 12 weeks, 65% of patients had longer strides, 55% had increased gait velocity, and 55% also reported improved balance.
The hope is that if we can engage people in physical activity early in the disease course, that we might actually be able to delay progression.
The therapeutic games could be available to the public as early as next fall. For Smart Planet,
so these were the things which where artificial intelligence with virtual reality can help you in getting the better functional outcome in the subject of the Parkinson's disease. And I think that next decade there may be some rapid changes in the healthcare sector. And now with a lot of sensor technology, cloud computing, that you can save the data in one device and you can open in another device. This will help us in better research also, and better research will also help us in better treatment planning, and better treatment planning will ultimately lead to better outcome of the functional outcome in the Parkinson's disease. And a lot of devices is coming up to measure the tremors, gait patterns, and the movement. Here is the one device which measures the tremor. You can see this is the device which can measure tremor, that 1 minute how much tremors he is having. We can assess pre and post the treatment, and then come to the better outcome. And we can plan a better exercises for having better outcome. This is another one for the initiation of the gait in the Parkinson's, and then as well as the gait cadence and the stride length. All this can be measured, and then accordingly assessment can be done, and then planning for the treatment. And these things will really help in subject of the Parkinson's disease for getting better functional outcome, and definitely to lead the better quality of life in the subject of the Parkinson's. Thank you, and thank you very much, all of you. So now back to Physio News. Yes, sir.
So thank you, sir, for your nice and informative presentation for today. And I think very new concept and very new things. And the basic from the Parkinson's disease we have learned during your lecture. And the lecture was, I think, it's very appreciating. And for artificial intelligence, I think it's a new concept in the treatment of this Parkinson's disease. And viewers, I would like to inform you that already we have given the link for feedback. So if you can fill up that feedback links, and then directly, instantly, you can get that certificate from there. And so please check the reply email on your mail which you are provided. So I think that is a great session, and I have to think that if there is any question, but already sir is not in, maybe some connection issue. So it's completed. No question is there. So it's okay. I think it's a nice session, and I will talk with you, sir, again in other way. So thank you, everybody. Already it's completed our that targeted session 1.5 hours, and it's gone. So I think there is no question. I think so. So yes, there is no specific question for that. So just fill up the feedback link, and you can get directly the certificate. And another issue, we will going to organize a such a another form in that sense. So next Sunday we're going to that is organize a workshop with. Give me a time. Hello, sir. Okay, sir. Okay, sir. Dr. Shamim, please connect sir with us, because we can just complete our session now. Dr. Shamim, would you please connect sir so we can end up our session with the question and answer session? Sir is on backstage now. Okay, please give me a time. I have to call Shamim. So another information, very nice information, that is the next Sunday, 13 September, we'll get our another professor in manual therapy. Yes, Shamim, sir is online, so please connect him on backstage. So next Sunday, we'll get Dr. Deepak Kumar Kepi, sir. I think that webinar will be very nice one, and subject and everything will declare soon. So another mentor in my manual therapy will come again with us. So keep joining with us and keep contact with us. So that will be great session. So we are looking for Dr. Shamim. Please connect, sir.